Welcome to the deep dive. Today, we're really tackling a big shift in healthcare. This idea of bringing the hospital right to the patient, the hospital at home model.
Yeah, it's a huge topic.
We've basically immersed ourselves in presentations from a recent World Congress, looked at it from, well, all sorts of angles.
Right, from the nuts and bolts of making it work on a large scale.
To the actual experiences of the clinicians doing the work.
Exactly. So we've got material covering implementation hurdles, some really innovative education stuff, and like you said, stories from the doctors and nurses on the ground.
So our mission here is to pull all this together, get the key insights out.
See where hospital at home is now and where it might be going.
Right, the potential, but also, the roadblocks. For you listening, it's about getting that quick, thorough understanding, hopefully with a few aha moments thrown in.
Sounds good.
Okay, so let's kick off with maybe the most fundamental piece, the change itself.
Yeah, a really good starting point. Pippa Schulman's presentation hit this head on. The challenge of just getting any big innovation going in healthcare.
She highlighted the role of doctors, right, and other professionals too.
Absolutely central. How they can either drive it forward or, well, stop it in its tracks.
There is that quote, doctors must be central players. Any change strategy they do not embrace is doomed. Pretty strong words.
It is strong, yeah.
Oh, yeah.
But it really hammers home the point. Getting clinicians on board isn't just nice to have.
It's essential. Makes you wonder, what are those initial sticking points? Why the resistance sometimes?
That's a great question. And it's complex. But what's interesting is, Schulman pointed out that often the biggest initial skeptics, they can become the strongest champions later on.
Huh. So you need to figure out how to bring them along, nurture that buy-in.
Exactly. Support their leadership potential. Because they're the influencers.
And a lot of that comes down to the workplace culture, doesn't it?
Definitely. Schulman gave this example, a partner program that started really slow. Like, the numbers were pretty low initially.
Right, I remember that slide.
But then they actively focused on the culture, and boom, significant growth, much higher numbers.
So it wasn't just about tweaking procedures.
No, it was a deliberate effort on the underlying norms, the values, what's specific cultural shifts. Well, things like opening up communication.
Letting staff actually contribute their ideas.
Yeah, empowering them. And visibly celebrating the early wins. That seemed key. It shifts the feeling from, oh, another talk-down thing to like, okay, we actually own this.
Shared ownership, belief in the model.
And if you think bigger picture, scaling this isn't just tech or protocols. It's rethinking how the whole organization works. Accountability is a huge part of that culture.
And not just for the hospital at home team, right?
No, it has to extend back to the main hospital, the bricks and mortar, as she called it. Maybe even community partners, too.
Right, it can't be siloed. Okay, and then there was the individual level. Schulman talked about motivation, engagement.
She used that donut analogy.
Yeah. The donut article. Resisting donuts in the break room. Seems random, but...
How does that connect to hospital at home?
Well, it illustrates these three basic psychological needs we all have. For engagement, anyway. Belonging, autonomy, mastery.
Belonging, autonomy, mastery. Okay.
Yeah. Feeling connected, feeling like you have some control and independence, and feeling like you're getting better at what you do, if you foster those.
People are more likely to get behind something new, like hospital at home.
Exactly. They're more likely to champion it. So thinking about autonomy, for example, how could a hospital give clinicians more of that in this model?
Maybe more flexible scheduling, more control over how they interact with patients, since it's, not the rigid hospital floor.
Could be. And Schulman also stressed that the type of organization matters a lot here.
Right. Academic medical centers versus regional systems versus community hospitals. Their reasons for doing it, the barriers they hit, where they put their money, it's all going to be different.
So an academic place might be thinking research, training.
Well, a community hospital is maybe more focused on cost savings or specific local needs.
Which means you can't just have a one-size-fits-all rollout plan.
Definitely not. It needs tailoring. And change takes time. Schulman showed that change curve idea.
Or the happy circle, more positive version.
Right. It maps out the steps. Find your champions early, celebrate those first wins to build buzz.
And figure out how to make it stick long-term. Sustainability.
Yeah. She mentioned Cleveland Clinic has actually published their framework, which could be useful for others.
So the end goal, really,
is to get past pilot projects. Make at-home acute care just a normal, valued part of how we do healthcare. Not an add-on, but core.
Okay, so that's the culture and change management side. Let's shift gears a bit. How do we actually train people for this?
Yes. Jeff's presentation on that Nordic project. Really fascinating stuff happening there.
Across borders, too. Denmark, Norway,
Wow.
Sweden.
Yeah, big collaboration. Hospitals like Northern Zeeland, Selke University Hospital, universities, even private partners
All working together.
to build this comprehensive online asynchronous education program for hospital-at-home skills.
And it makes sense for them to do it together, given, like Jeff said, there's similar healthcare systems.
That shared foundation helps a lot, allows them to create training that works across the board there.
And they're not starting from scratch entirely?
No, they're building on existing work, pilot programs, even some randomized trials. Jeff mentioned one at his own hospital. Results due after summer 2025, I think.
Okay. So similar efforts in Norway and Sweden, too.
Right. So even though policy might support digital health and the evidence for hospital at home is growing.
It's not really widespread there yet.
Not quite. They're seeing this education piece as key to getting over that pilot sickness, as Jeff called it, to really enable scaling.
Pilot sickness, I like that. So it's about making clinicians feel safe and confident.
That's a huge part of it. Feeling prepared for this different way of working. Jeff referenced that Cochrane review, highlighting the need for support.
They also had to nail down the definition first, didn't they?
Oh, yeah. What even is hospital at home? Compared to, say, outpatient monitoring or just home treatment.
You'd publish something on that.
In a Danish medical journal, yeah. Getting that taxonomy clear. Because you need standard terms.
They're talking about it for research, for training.
Exactly.
Yeah.
And their curriculum reflects that clarity. 5 modules.
Covering patients at home, communication, e-health skills.
Technology, data, and quality improvement, patient safety. Pretty thorough. We're 5 ECTS points, too.
Wow, 5 ECTS. That's substantial. Signifies real academic weight.
It does. Got 125 to 150 hours of work, roughly. And they put a lot of thought into the actual competencies needed.
For experienced clinicians versus students?
Right. Focusing not just on knowledge, but reflection, building a best practice catalog together.
And using simulations. Gamification.
Yeah, for skills like patient screening, teamwork in a remote setting. Pretty innovative.
And they're testing the education itself.
With a randomized trial across all 3 countries to see if it actually works.
That's proper rigor.
It is. And the early signs are good. Jeff said beta testers reported feeling more confident, braver even.
Braver, interesting word choice.
And maybe the best part, it's all open access, free for anyone globally to use and adapt.
That's fantastic. Real knowledge sharing. Okay, let's jump across the pond now to the U.S. and Canada, rural settings specifically.
Right. Ryan Brewster's presentation, looking at the clinician experience directly.
Which, as he said, often gets overlooked. We talk a lot about patients, systems.
But what about the people delivering the care? Especially with burnout being such a massive issue in traditional hospitals.
Depersonalization, exhaustion. So, yeah, how does hospital at home affect that?
That was the core question. And they looked at it within this multi-site trial in rural areas. Big challenges there, obviously.
Distance, resources.
Exactly. They talked to doctors, nurses, APPs, paramedics. A good mix.
And found 5 main themes.
Yep. First was perceived quality of care. Generally, clinicians felt pretty confident. Often saw it as equal to or even better than inpatient care.
Why better?
More personalized care, patients moving around more, maybe fewer unnecessary meds, lower infection risk. They felt okay with remote care, telemedicine, like the tech, mostly.
Mostly.
Well, one APP wished they had that tech back in the main hospital. But yeah, unreliable internet or challenging home conditions were concerns for safety sometimes, especially rurally.
That makes sense. What was the second theme?
Clinician perceptions of the patient and caregiver experience. Overwhelmingly positive again. Patients seemed more comfortable, the care felt more patient-centered. Build strong relationships.
But they were aware of the caregiver burden.
Very mindful of it, yeah. There was an example of a nurse giving out their personal number. Shows that connection, but also, the extra responsibility.
Okay. Third theme.
Clinician job satisfaction. This one really stood out.
Yeah.
Many felt a deep sense of professional fulfillment.
Why?
More empathy, compassion maybe, from being in the patient's home environment. Plus, they value the agency.
Agency.
Yeah, more autonomy, lower patient loads, like 1 to 5 patients typically, more control over their schedule, fewer interruptions than on a busy ward.
That sounds pretty appealing, honestly. Could that help with burnout?
Potentially, yeah. That's a really significant finding. Fourth theme was team collaboration.
How did that work remotely?
Surprisingly well, it seems. High autonomy for the frontline folks, good communication, lots of trust between nurses and physicians. They felt reviewing plans together might even be better than in the hospital. Less hierarchy, maybe.
Interesting. I might have guessed the opposite. Okay, so what was the fifth theme? Sounds like it wasn't all smooth sailing.
Right. The fifth was implementation challenges, getting the program running.
The practical hurdles.
Exactly. Resistance from some referring doctors, both inside and outside. New workflows for logistics, admin.
Yeah.
Transportation in rural areas is a big one.
Huge distances sometimes.
And staffing limits. That was a frustration. Wanting to enroll more patients, but just not having the people. One doctor quote really highlighted that constraint.
So the day-to-day experience for clinicians was positive, but getting the program scaled and running efficiently had bumps.
Especially in those rural settings where resources are already stretched thin. Brewster did note study limitations, mostly white, English-speaking patients, extra support for the study sites.
Right, important context.
But overall, largely positive clinician view. Suggests this model could protect against burnout if it's well supported. Really stresses listening to the workforce.
Absolutely. Okay, let's switch to tech now. Point of care ultrasound, POCUS at home in Taiwan.
Yeah, HAHC's presentation, really cutting-edge stuff. Their hospital at home program just launched July 2024.
Wow, that's recent.
And they're already integrating POUS, focusing on infections, patient-centered models, teleconsults, even mobile clinics linked up.
That's incredibly fast integration. How did they manage that?
Very systematically. Develop educational materials and clinical consensus together, hospitals and home care teams collaborating.
Lots of meetings, case reviews.
7 expert meetings, reviewed 18 cases, developed guidelines using grade criteria for evidence, really rigorous. Built a website for the recommendations.
So POCUS at home wasn't totally new. It gained ground during COVID.
Exactly. Showed its value for hospital at home and chronic disease management. HAHC, we mentioned they prefer wired ultrasound devices in Taiwan.
For reliability.
Yeah, seems so. And the uses are broad heart, lungs, legs for clots, abdomen, joints, even guiding procedures at home.
Procedures at home with ultrasound guidance.
Oh, yeah. Chapter 2 of their guidelines apparently has cases showing improved outcomes because of POCUS at home, respiratory issues, heart failure.
They even adapted that fast exam protocol, added knee scans.
Yep, the EFE protocol. And they're really pushing telemedicine with it, especially for rural areas. That model of a teacher guiding students remotely via video.
That was really neat, using a structured reporting framework, too.
It's a smart way to bridge the gap. They have protocols for teleconsults involving nurse practitioners, even using POCUS for advanced care planning discussions.
Wow, and tying it into med school training.
Right, using the ED as a hub, letting young doctors get POCUS practice in this setting. They've run tons of workshops, too.
Hands-on training.
35 workshops, trained over 800 clinicians. Nurse practitioners use specific POCUS notes for handover.
So the research shows it helps with diagnosis.
Yeah, symptom-guided POCUS helps narrow things down. But HAHC also mentioned challenges. Integrating with EMRs isn't perfect yet. Need more government and manufacturer support.
Still working out which handheld devices are best for which specialty at home.
Right. And they want to involve NPs more in handover training, use high-spot modules for education. It's all about building this comprehensive, patient journey-focused model. They've even published textbooks. Chinese version coming soon.
Amazing pace of development there. The Q&A added some good details, too, like how the Nordic project determined competencies.
Yeah, that collaboration between university learning experts and hospital clinical experts, cross-country, cross-sector, seemed really beneficial.
And how they're measuring the Nordic program's success, that crossover trial design.
Falling outcomes at 3, 6, 12 months, then giving the control group the education, too. Pretty robust.
And the U.S.-Canada trial method, semi-structured interviews, iterative coding. Good transparency there.
Definitely. Then the discussion about junior doctors.
Right. Often not in the standard curriculum yet, but important for the future. Early exposure might reduce that institutional resistance later.
Good point. And that link between change management and education training can address biases early on.
Did they mention intrinsic motivation?
Yep, it's actually an outcome measure in the Nordic education trial. They're looking at it.
Smart. And the POCUS specifics, doing it at home versus in the hospital.
Focusing on primary surveys, key questions. Checking volume status before an IV. Using that EFE protocol for initial screening by NPs before the doctor consult. Makes sense.
The big question, though, when will this stuff be standard in medical training?
Huh? The million-dollar question. Challenging. The Nordic project hopes to boost teaching volume, but integrating new things into curricula is slow.
There was some optimism, though. Global momentum, reimbursement changes. burnout.
Yeah. And personal anecdotes, like residents learning about it from podcasts, plus new master's programs, fellowship plans. It feels like it's gaining traction, but it needs full engagement.
Okay, so wrapping this all up, what are the big takeaways?
Well, it's clear scaling hospital at home is complex. Culture and individual engagement are absolutely critical, maybe more than we initially think.
And we're seeing real innovation in education, like the Nordic approach, and in tech use, like POCUS in Taiwan. Those are promising paths forward.
Plus, the clinician experience, while challenging sometimes, seems largely positive in these newer models. That potential impact on job satisfaction and burnout is huge.
So hopefully for you listening, this deep dive gave you that shortcut understanding, maybe some surprises too.
Like the donut article relevance.
Right.
Or just how fulfilled clinicians can feel. Or the sheer speed of innovation in Taiwan.
Right. And maybe a final thought to chew on. Think about how these themes, culture, education, clinicians' impact, apply elsewhere.
Yeah, and other healthcare changes, or even totally different fields,
Yeah.
What's similar? What's unique about bringing complex stuff into, well, unconventional settings like the home?
Lots to think about. Definitely worth exploring the programs and research we mentioned if this sparked your interest.
The deeper you look, the more there is.
Thanks for joining us on The Deep Dive.